For this month's Zoomustahan, we are featuring Dr. Jasper Tolarba. Dr. Talarba is a US Fulbright Research Scholar from 2019 to 2020 at the Kingdom of Jordan. He received his doctorate in nursing practice from Yale University in New Haven, Connecticut, where he concentrated in health policy and executive leadership. He holds a Master of Science in Nursing from Xavier University in Cincinnati, Ohio, as well as Masters of Arts in Education from Bicol University in the Philippines, where he also earned his Bachelor of Science in Nursing. Dr. Talarba is currently pursuing a second doctorate in nursing education from Teachers College, Columbia University in New York. He has held various positions in his career, just to name a few: Director of the Global Standards and Qualifications at the CGFNS International, Clinical Nursing Director at Tufts Medical Center, Patient Services Manager at Yale New Haven Hospital. He was named by LinkedIn as one of the 50 future leaders of nursing in 2019 and 2018. Received Excellence in Nursing Administration by PNANE for New England. He is also a published author. His recent book is entitled Handbook for Filipino Nurses Immigrating to the United States. Please join me in welcoming Dr. Jasper Tolarba.
Thank you so much, Annie, for that generous introduction. Just one quick caveat or maybe correction. The handbook was actually not, I was one of the authors, but it's actually a multi-authored endeavor from the other members of PNAA, more like the more seasoned PNAA members. So I was just invited to be one of the chapter authors, but thank you so much for that. And I believe Dino has a copy. So if just to plug it in, if anybody needs a handbook for Filipino nurses for yourself or for your friend or for those other, future nurses coming into the United States, please feel free to share that link, Dino, if you don't mind. But I believe it is available on the PNAA website. So just to give everybody a heads up about that. But anyways, going back to our event today, I am very fortunate to be invited by Dino, who's a good friend of mine from way back 2015. We first met in PNAA. We were both invited as speakers, and then from there we kind of, became good friends through different events of the PNAA. And today I am very fortunate to be speaking with, luminaries of the alumni of St. Louis University, and I am very happy to, be an invited speaker. St. Louis is a very, prominent school in the Philippines, as we all know. I didn't get the chance to visit St. Louis yet, but I do have some friends from St. Louis, so I hope they are part of this, or if not, I'll tell them that, hey, I was invited to be a speaker in your alumni. So anyway, so today I'm actually going to talk about global nursing shortage amidst the pandemic. The topic that I would like to share with everybody today is about the current critical shortage of nursing, not just in the United States, but it's actually a global phenomenon. And I want us to be, as most of us here are internationally educated or foreign educated, however you want to call it, but I would like us to be cognizant about what is going on, not just within our hospital or our state or in the country, but more so on the global scale, because all of these phenomena are affecting our practice. So, and at least you will be able to kind of understand why things are the way it is when you are in your own clinical practice or in your academic setting, if you're teaching, so to speak. So in the next slide, I have highlighted some of the learning objectives that I have in mind today for this 40-minute, I think 30, 40 minutes. I'll try my best to not talk much and finish within that time period. And so I'm hoping that at the end of this session, I'll be able to describe the patterns of global nurse supply and mobility. I will also try to discuss the impacts of COVID-19 on the global nursing workforce and discuss about some policy that can be taken to sustain the nursing workforce moving forward post-pandemic. Next slide, please. All right, so let's first understand what happened or what was the situation and status of the nursing profession and the nursing workforce prior to COVID-19. During the time, I would say December 2019, and backwards, the entire nursing workforce globally is about roughly 28 million. So 27.9 million nurses globally. And we all know that in a healthcare setting, be it in a state or globally, about roughly 60% of all healthcare workers are nurses. So we are the majority of the workforce of any hospital or in the global setting of the entire global healthcare workforce. Nursing constitute the more than half, actually. So even if you combine doctors, physical therapists, social workers, etc., we still outnumber those healthcare workers. So nurses, that's why they love us so much in the hospitals, right? Because we have a voice, we have the majority of the staff. So out of the 27.9 million nurses, we were already short 5.9 million nurses. So as it was at the time, prior to COVID, we are about 6 million nurses short. So we were just cruising by status quo at that time. So we knew that we were strapped with the ideal supply of nursing or staffing, so to speak. And on top of that, we were foreseeing, as far as trending was concerned, we were foreseeing that 17% of those nurses at that time were going to retire within 10 years. So that's why you probably heard about 2030, right? We're going to be short of nurses still, the 10-year projection. And this was not even talking about COVID. And because of that 17% that's going to retire, we were short 4.7 million nurses just to maintain the workforce, right? So because 17% of 27.9 million nurses is equals to 4.7. So if you add 5.9 million nurses short at that time, plus the estimated 4.7 million, which is the 17% of nurses retiring, we were projecting 10.6 million nurses short. This was pre-COVID, pre-pandemic. On the next slide, when COVID hit, we were now 14 million nurses short globally. And that's because we already have that 10.9 million nurses leaving, right? 11 million, plus the 2.2 to 3 million nurses that are projected to leave the profession because of COVID traumatization. So that 3 million, in addition to the 11 million, will result to about 14 million nurses short. So I'm telling, every time that I have, a talk, I always say to people that in nursing that it's not going to get better anytime soon. And unfortunately, 80% of nurses have reported mental health distress, as you probably have experienced yourself, unfortunately. Next slide, please. So just a little snippet of what's the COVID-19 effect. They call it COVID-19 effect or traumatization of nurses. In Japan, 15% of hospital nurses are resigning from their jobs. That's the statistics in Japan. In the United States, 76% have reported exhaustion and burnout. And the other statistics for that is that 93% have reported being stressed and overwhelmed. And I guess we're part of that, right? In Brazil, 49% of nurses report anxiety and 25% report depression. China, 60% of nurses report exhaustion and 90% report anxiety. Africa, 20% of healthcare workers report daily depression symptoms. Spain, 80% of nurses report symptoms of anxiety and burnout. And finally, in Australia, 61% of healthcare workers report burnout and 28% report depression. So there's a lot of, psychological, impact that this COVID-19 has brought to, especially the nurses, because nurses are really at the front line, at the forefront of this pandemic. Next slide, please. So what is the impact of nursing shortages? I think this is very, you all live by this effect and impact on a day-to-day basis, right? So for the nurses, they have less time, with the work. So because of that, they bypass safety protocols, and sometimes there's incomplete communication. And therefore, the impact of that is that there's lapses of continuity in treatment. There's less attention to details. They are prone to make mistakes. And there's also risk of, medication error. They are more stressed. Therefore, they are, they have poor job performance, potential for poor job performance. And again, greater risk for med error. And finally, they cut corners. They compromise quality of patient care. And again, patient impact for outcome of the patient. Next slide, please. Now, this slide talks about, and I got this from one of the prominent researcher on nursing workforce globally, and he summarized what the trajectory of COVID-19 during the start, during, and then after. So this slide, I won't read this to you, but basically it's a lived experience for most of us nurses, right? During the first wave, the surge capacity, there was like critical, hospital critical situations. We focus now on ICU care, and then we have all the nurses pick up extra hours on their timesheet. We redeployed nurses from med-surg going to the ICU. Even doctors had to work in the ICU. Even student nurses, heard in New York, they are now doing some, procedures that were originally only for licensed nurses. And then we fast-tracked IENs, or international educated nurses, in terms of acculturation and then in their work, joining the work setting. And then in the transition phase, which is like during the COVID, we have more system preparedness. There's now managing to track services, the COVID and then the non-COVID situations. We kind of return to the usual staffings systems. We reduce the volunteer and then the return to classrooms of the students. And then the new normal, right? So now we're looking at growth of COVID-19 related chronic care. We train more nurses to specialize in ICU. We do retention of current nurses and increase supply of new nursing staff. Next slide, please. Now this graph kind of shows how COVID-19 kind of predictably increased the demand for ICU nurses. We all know that. But what was interesting, that's why I included here in this slide here, is that there are some states, right, that had some increase. They all had increased during the peak of the COVID-19, but then they never rebound. They actually, some states had managed it quite well, like New York, Massachusetts, etc. But there are some states that instead of managing it quite well, the surge, they actually had, tremendously increased their demand. And the reason for that is obviously there are more patients, there are more need for healthcare professionals to take care of patients. So therefore, this demand for ICU nurses increased. So states like Texas, Florida, Arizona. So those states are increasingly having vacancies for ICU nurses because the number of, COVID-19 patients are increasing in those care settings. Next slide, please. And because of demand, as we all know in our economics 101, right? Demand and supply. Now we are seeing job offers that's ridiculously quite, I don't know. I was asking last night, I actually posted last night in my Facebook, like, can we actually, what's the term, accuse some of our peers of price gouging because they are now receiving up to 12,000 a week, imagine, per week of salary, or 10,000 even for those nurses. And I kid you not, they are actually, hospitals are willingly offering those salaries for those nurses. And it's not going to subside anytime soon, right? Because the need is there. And let me tell you this, the hospital nurses are actually resigning from their job because they want to travel, but then they are traveling to the same hospital they're working in. And I have seen this happen, right? So the nurse managers were okay because now they don't have a choice. Instead of losing their nurse to travel somewhere else, they're saying, okay, instead of resigning, you can go apply for travel nursing, but then you can still work for me. But you're just not just in my payroll, but you are getting paid as a travel nurse. And they're desperate. Desperate times get desperate measures. So that's what's happening right now in our country. Next slide, please. This slide is actually just looking at some data on how many internationally educated nurses. I think it's also important because we all are, I'm not sure about the attendees today, but I think majority, if not all of us, are internationally educated nurses, right? So then we have to kind of know where is our place in that portion of the pie, so to speak, in the nursing workforce in the United States and globally. So as we have said, there's about 6 million global nursing shortage, and 550,000 IENs are in 36 high-income countries. So these are countries like Germany, Australia, US, UK, etc. Right? So the OECD countries. Out of the OECD countries, there are actually 240,000 Filipino nurses in those 36 high-income countries. And I'll show you the slides next in the presentation where they are specifically. Then the next from the Filipino nurses are actually Indian nurses. In the United States specifically, there are about 197,000 IENs. In the UK, 100,000. In Germany, 71,000. And in Australia, 53,000. In next slide, if you don't mind, you will see that IENs are located in these countries, okay? So you think United States is the country which gets all the Philippine nurses, but it's actually not. As you can see, New Zealand is the #1, then UK, next, and then Canada. Oh, sorry, I missed Australia, then Canada, and then United States, and all the rest, right? So that's the distribution of the foreign educated nurses as far as global distribution is concerned. Next slide, please. I think this slide has been a slide in our bachelor's course in economics. But I just want to reiterate why it's very important to still talk about this, because this is still the push and pull factors that's happening, right? So the push would always be the salary, low salary, the career opportunities, the lack of professional respect, poor retirement benefits, poor working conditions, and the tradition of migration, right? So all of our classmates and all of our friends are abroad. So now, we always say, when we take nursing in the Philippines, we always get asked during our first year, like, what country are you going into, right? So that's how it is, I guess. And then the pull is always going to be the opposite: the high salary, career opportunities, the autonomy that we have better way of life here, working condition, and our families and relatives and our friends are here. So those are constant push and pull factors for nursing migration. Next slide, please. Now, because there's always the migration, because nobody can stop migration, right? I should not say that, because remember recently President Duterte kind of issued that executive order that only 5,000 nurses can exit the country. But I guess right now it's more relaxed. But I'm talking about critical countries. When I say critical countries, we're talking about out of 188 countries, there are 20 countries in the world where 50% of their graduates are actually leaving as soon as they graduate, right? So imagine in the Philippines, if we graduate like 50,000, and then like 25,000 leave the nursing workforce, is going to be, I think, a problem. And that's the current situation with these 20 countries. These countries include Caribbean countries, Pacific countries, and then African countries. So therefore, the World Health Organization actually took a initiative to tell recruitment agencies that they cannot recruit from these specific countries. So that's why you will rarely see countries coming in from this specific country, because recruitment agencies are quote unquote banned from recruiting from these countries. Next slide, please. So what are the policy actions that we can take in order to mitigate these circumstances of global nursing migration? At the country level, we have to assess and improve nurse workforce data. So that means, for example, in the Philippines, we have to know how many are graduating, what's from those that graduated in a specific year, how many actually went to work in the nursing workforce in the Philippines, and how many are leaving, right? So those are the data. And then also those nurses who did not take a job as a nurse, but are employed in other industries. So those are some of the data that needs to be tracked, right? So we need to have those data. And then we have to expand the capacity of domestic nurse education system. So that means that we should not have schools that are kind of diploma mill. And I've worked at CGFNS, so then I've been with CGFNS for 5.5 years. So I have seen it all, I guess. So if you can say that, looked at different curriculum from different countries, and especially the Philippines, because most of the applicants are from the Philippines. So I have encountered schools, unfortunately, diploma mills still, and sometimes I'm sitting in meetings, and then I'm embarrassed for my own country as a Filipino to see that there are some schools that unfortunately are just even issuing diplomas, and for a fact that there's no possible way that that person could have finished the program because of other circumstances. That it's a recto a diploma and transcript. So I'm embarrassed, but it's not new. So it's a known phenomenon. That's why I guess certain organizations are there to do the vetting to make sure that there are some safeguards to make sure that the workforce are legitimate, right? And again, we can talk about those scenarios where they're practicing as a nurse because they passed the NCLEX, but they never went to school as a nurse in nursing in the first place, right? And it was in the newspaper, but that's on another day. Then retention, attractiveness of nursing as a career. Again, we all know that in order for us to retain nurses, the retention or the attrition always, has something to do with the pay in the Philippines, right? Still, for the longest, salary grade, 11 instead of in the law, it says salary grade 15. But hey, they always say DBM says, well, we don't have money, so we can pay you, sorry, next time. It's absurd. If it was in the United States, everybody's up in arms, but it's the Philippines, what can we do? I guess I should not be too pessimistic on that. I think it's up for us as nurse leaders, right? As alumni of our institutions, nurse leaders, to go back to our country to help our fellow Filipino nurses and our colleagues there to kind of speak up for the right thing and to make sure that our nurses are paid properly. And sometimes I try my best to not post anything on Facebook, something political, but when I see things happen where nurses are working on the front lines in the Philippines, and then their hazard pay is 200 pesos for the 3 months that they worked, that gets my blood boiling. Or they have been working for so long and they have 3 months back pay, they have not getting paid. It's not, I don't know. I guess we'll talk about it some other time, but for now, I'm just going to say that we as nurse leaders, as nurses who are now on the other side and can see and has a voice and see what's wrong and right, we should go back and advocate and be the voice for our peers in the Philippines. Okay. Then next is to support advanced practice nursing. And that's something that I'm also passionate about. I've been talking about advanced practice nursing. I have a couple of talks that I had in the Philippines with the Board of Nursing there. So I have been advocating because they were submitting a bill and currently it's approved already in the Congress. And so it's now in the hands of the Senate to approve the provision for advanced practice nursing. So I've been advocating for the signing of that provision in the new bill for the nursing law. And then finally, monitoring and tracking the nursing self-sufficiency. So that means that making sure that we are aware on our own. It actually applies more on the United States. And let me tell you why. In the United States, they say, oh, we're short of nurses, but they are actually very confident that there are more IENs that are coming in the United States. So they don't encourage to recruit more nursing to come to, to enroll in their nursing schools. Instead of inviting or improving their nurse faculty or increasing their nurse faculty supply, they really don't, salary of nurse faculty, unfortunately, is not being prioritized. So therefore, you have more nurse faculty shortage. And as a result, you turn away all those, high school that want to go take up nursing because you don't have enough faculty. So that's what it means by tracking nursing self-sufficiency, being that as a country, the United States has to take care of its own nursing pool by making sure that their schools can take in more nurses so that they can generate more nursing graduates. So I guess that's how I want to put it. Next slide, please. And in the international level, we have to commit to effective monitoring of international flows of nurses. And this is kind of the same with, data gathering, like how many nurses are migrating to the United States, how many are going to the UK, and so on. Because tracking this is very important in terms of looking at the criticality of the nursing supply. So if we have 100,000 nurses graduating in the Philippines, you don't want to have those 100,000 come to other or go to other countries for migration. So in the international level, you have to have some safeguards and data monitoring for those numbers. Commitment to ethical approaches to manage international supply of nurses. I think Dino is very involved in this with the PNAA, where we in the PNAA always, look up to nurses, especially those coming in, fresh from the Philippines, to make sure that they are not, taken advantage of by recruitment agencies. So PNAA is always open for those complaints from them. Then commitment to supporting regular national nurse labor market analysis, kind of similar to what I have mentioned earlier, where supply and demand, you don't want to, kind of like let loose of the guards, and nurses can just dictate however much salary that they want to have. And finally, commitment to investing in nurse work for sustainability in small, lower income and fragile states. So those countries that are really critical in their nursing shortage, we should not, as much as possible, take more nurses from them. Even in the Philippines, right? So we know that we might think that Philippines has a lot of nurses graduating, but actually, if you look at the nursing workforce in the Philippines, you still don't enough nurses working on the bedside, because there are not many positions or plantilla positions in those hospitals. And now, if you don't have nurses if you have nurses working in those plantilla positions, and then you allow nurses, seasoned nurses from those, especially some UST or St. Luke's or UPPGH, those seasoned nurses now start to migrate. Then you're left with newbie nurses taking care of patients in the Philippines, and we don't want that to happen. And then next slide, I think it's my last slide. And this is a quote that I just grabbed that shows, kind of summarizes what we as nurses kind of show the world. Before they think that nurses are, cool. We are portrayed in TV like, I don't know, the nurse Jackie kind of image. But now, after the pandemic or during the pandemic, we have shown how nurses are really the frontliners, smart, dedicated, skilled, and caring professional nurse. We laid, ourselves out there and, risk our lives, lives and, our lives and limbs just to care for other people during the pandemic. So I think with that, I would end my presentation. I have my cell phone number there and also my email. If you feel, we have more, things to discuss, or if you have any questions, please feel free to reach out.
Thank you, Dr. Talarba. That was a very reflective.
Oh, thank you.
Very insightful presentation. It made me actually, first of all, when you mentioned that you worked for CGFNS and how you had to filter all those nursing applicants, it made me, or I'm sure my colleagues here would agree with me, that made me realize how grateful we are for getting the great education that we have had.
Absolutely.
Because we can be dispersed into the international medical market, if you might say, that we can function anywhere that we can because of the education that we received. So that was so reflective. Thank you so much.
Yeah.
I'm pretty sure that we have other questions, so we open this time for the other participants to ask questions. If you have any, please, you may unmute, or you may enter your questions in the chat box, and we have Kay and Karen to read those questions as well. Oh, go ahead, Claire.
I have a question as well.
Sure.
Okay. Thank you very much. So a lot of those data that you talked about was very insightful. I've attended about 10 years or so ago, I attended an urban, international urban conference that basically talked about the brain drain from developing countries, and the mere fact that and putting a number or a dollar cost on really talking about the resourcing of this struggling countries to educate their professionals, including nurses, right?
Yeah.
Like, how much cost does it take for a developing country to actually spend to educate say a nurse, and that they go to developed countries, and these developed countries don't even sometimes they get difficulty getting their recognition, and the mere fact that these developing countries don't really realize that actually they're draining the resources of that country, and that sort of that shift, the paradigm shift in thinking, made me realize that it is true, right? Like they come here, or they come to a country, and sometimes we create difficulties for them to actually get certified and get to work, and they have to go through hoops and everything to get recognized. But then we don't realize that actually they're actually getting someone who's already been trained and resourced for over 4 years or 5 years to get their degrees, right? And now, do you have anything more on data like that at all?
Yeah, I think you're absolutely right about the financial aspect of things, and you're absolutely correct when you say that the receiving countries such as the United States and the UK, they are saving a lot of dollars or money for taking all these foreign educated nurses, right?
Because they were saying too that even if, say, for example, the United States, if you put together how much they spend to support in terms of aid, support the country in terms of aid, it won't. You can even put put a number and make it times 10, and it won't even be enough to basically replace what they drain in terms of the resource. Right?
Absolutely. And we all know that training. I know that when I was still in the clinical areas. I was the director of nursing at Tufts, and we know my CEO and CFO at the time said that in order for me to replace a nurse that left, right? So we have a nurse that we hired, then went to orientation, worked for a year, and if that nurse drops for a year, we are going to spend $50,000 just to replace that one nurse. So that's why the attrition is very important, and also the retention of the nurse. Because imagine for a facility, they would spend $50,000 for recruitment of the nurse, training the nurse, etc. And that includes the preceptorship and all. And that is why it's tied to, if you can see, hospitals willing to pay sign-on bonuses of up to $10,000. I've seen some sign-on bonuses of $25,000, because even with that, they are still saving a lot of money for replacing the nurse. And they love IENs because we are tied to that 3-year contract, 4-year contract, right? So that kind of secures their whatever sign-on bonuses that they give out, that they can get it back during that time period for the service.
Thank you, Kuya Cliff. Do we have any
Drive
other
safe,
questions?
Cliff.
Do we have any other questions before we go on? We have 2 books of the book that Dr. Jasper has co-written that we'd like to give away. And
Question.
Go ahead, Gail. Sorry.
Hi, Dr. Jasper.
Hi,
Thank you
Kate.
so much I know how busy you are, but I know that you've mentioned that you're advocating for more nurses to go and be advanced practice nurses. One thing that most Filipino nurses that I have talked to, encouraging them to take their master's or their DNP, is that they are saying that they're making more money in working in an acute setting as an RN with their BSN as compared to working as a nurse practitioner in a clinic or joining a medical group. What are ways that we could encourage more of the Filipino nurses, because they're really smart, talented, but it's just this pay issue is something that's stopping them from really taking on a new role.
That's a very good observation, Kay, and you're absolutely right. Sometimes you gotta have to think about the long, how do you call it? Not just what is, but what will be in the future, right? So there's nothing wrong with staying at the bedside with your bachelor's. Definitely nothing wrong with that. If that, not everybody would like to change. Not everyone want to be a nurse practitioner, change their scope of practice, whatnot. But I always say this to students that I teach for a bachelor's, so I also do adjunct faculty at UMass, and I always say to them, with the bachelor's students, I always say to them, after you finish your bachelor's degree, I encourage you to get like 2 years, at least 2 years of bedside experience, and then after that, you have to again go back and ask yourself, am I clinically ready for another role as a nurse practitioner? Okay, because not in the future, you don't want to be at the bedside. If you are ready, you have the resources and the expertise to now go into another role of expanding your scope of practice as a nurse practitioner, then you have to challenge yourself, because as an advanced practice, you actually have more means to impact your patient care, the patient care population, not just one patient for the shift, but you now have more independent practice as a provider, as opposed to a clinician at the bedside. Now, my answer to the question is, yes, you may be earning more at the moment, and that's probably because of the supply and demand, the economics of today's times, but in the long run, it's not going to be sustainable. Post-pandemic, those salaries that you're seeing even from your hospitals or even for travelers, it's gonna, go down. And then later on, 10 years, 15 years, you probably are hurting your back. You don't want to be lifting patients later on, right? So that is exactly why that was my motivation for myself to pursue further studies. But then again, if that's a conscious choice for the nurse to stay at the bedside, I totally admire that. But again, it's a personal choice that we cannot, it's a individual respect for their decision.
Thank you so much, Dr. Jasper.
Yeah. I was kind of surprised to see Norway show up on that slide with higher numbers than the US.
Mm-hmm. Even Germany, I didn't know that, because the language barrier. Yeah. They still have a lot of nurses going there.
Right. So, okay, there's two other questions here. One of them is about the pandemic. Did you want to?
I think we can just read one, I guess, so, and we can get to.
Okay. I can read that. So what inspired you to co-write that handbook?
I'm actually just by accident that somebody invited me to co-write. So I don't exactly know. It's through Dino, probably Dino or somebody from PNAA said, Jasper, we need you as an editor for this. So because I have some experience with editing in my college career, and so I was the editor of our university publication, so I love editing. And so I edited, originally was the kind of editor. So it's a minor task, just kind of doing grammar. I also doing the layout, whatever. Then eventually, as the the other folks already wrote their chapters. And then I realized there's a chapter that was missing about foreign education and their acculturation when they want to pursue further studies, like if they want to go the DNP track, if they want to go the PhD track. So I said to the my colleagues, do you want me to write about this particular subject matter, because I kind of know about it? So they said yes, by all means. So then I wrote a little bit of a blurb about that particular topic on nursing education, if they want to pursue either a further studies as a nurse practitioner or a PhD versus a DNP, which one they have to choose. So that's how I ended up. But it was like an accident. It was not like conscious thing that I decided to write that. But so yeah.
Thank you for sharing that.
Yeah.
Now, speaking of the handbook, should we give away one of the handbooks? Okay. We have a question for all participants. Give an example of a policy that countries can implement to improve the international supply of nurses post COVID-19. Dr. Talarba mentioned that in his presentation.
Ate Anne-Marie, and who else have their hand raised? I see. Okay, Ate Anne-Marie.
No. I was raising my hand for a question, not to answer
for a
that.
question. Oh, okay.
Later. I'll ask the question later. Sorry.
Go ahead, ask the question.
Hello. So, I'm Anne. With the present pandemic and the shortage, what is the current situation of nurse recruitment, like global nurse recruitment? We know that people cannot, like some nurses, in the hospital that I work at, I asked the admin one time, like, okay, you're using this and that. What's with international recruitment? And they said they are having a difficult time recruiting nurses at the moment. So what is the current situation and what is being done about it?
So there's a lot of political factors, getting into the way. The election in the Philippines, we have the pandemic, we have some relationship between countries and amongst countries. So there's not one single factor that we can point, unlike before when we say, oh, it's the supply and this. But in today's times, I think there are several factors affecting it. I kind of briefly mentioned about when the current administration of the Philippines issued an executive order saying that, no, we only have 5,000 nurses going out of the country, and that's about it, right? So I heard last month that 5,000 was already filled, so nobody can go out. We are at the mercy of those kind of executive actions from the administration. So that's one. There are also situations where I'm not sure if you're familiar with the Eb3 visas, where Eb3 is like there are only 25,000 visas available every fiscal year in the United States. So that Eb3 visa, work visa, is shared amongst different industries. So we have the techs, we have the nurses, physical therapists, etc. So those are being raffled upon on how many nurses get into those Eb3 visas. But currently, the good thing is it's now available. It's current. If you look at the visa bulletin, it's current. Unlike during my time, I don't know about you, about 1996, I graduated in 96. When I graduated, there was like nothing, because the visa availability in the United States at the time was 10 years retrogressed, right? The retrogression, where the availability of visa is like 10 years behind. But now it's current. So I'm telling nurses in the Philippines nowadays, you guys are so lucky. You graduated now, you take your NCLEX in 1 year, 2 years time, and then you go to the United States. How cool is that? So the other thing that I'm trying to kind of mention is also the recruitment agencies. We have what we call the direct hire nowadays, right? So there's not much about the agency. You know, we're seeing less and less of that agency where they are the employer, the employee of an agency. But now we have more direct hires where the hospitals are now directly hiring and interviewing IENs, and then they go there directly. And finally, you know, salaries, of course. So how much salary, and I think the other thing probably you guys would like to consider next time is some ethical consideration for another Zoom talk in the future. What are the ethical or unethical practices of recruitment agencies? Because we are seeing this a lot. You know, Dino and I are privy with some of the complaints because Dino was previous president. I'm actually co-chair for the ethical in PNAA, ethical committee. So then whenever there's a complaint to PNAA, we kind of get looped in. And so we are seeing hospitals, sorry, let me correct that. We are seeing recruitment agencies trying to sue their Filipino nurses in the tune of like $90,000 for breach of contract or $120,000 breach of contract. Like who has $120,000 to pay their recruitment agency after 2 years of arriving in the United States, right? So I think that's for another day of discussion, but I think that's one of the things that probably will help us as international educated nurses trying to help other nurses coming in the United States to really advocate for them, because it is not right that we are seeing those nurses being abused by these recruitment agencies. So all these different factors are, you know, have a lot of things in terms of hospitals getting nurses from the Philippines.
Dr. Jasper, I might be putting you on the spot, but it will be good for our new graduates from the Philippines. So
Absolutely.
We'll time it for next year as they graduate in like, I think maybe March. And then we'll have another talk regarding unethical practices of recruiters, because it's not talked about that much, but it's really something that's going on that you said. So we'll put you on the list.
Absolutely.
Okay. Your fellow Yale person here at the Afi, please unmute yourself and ask your question to Dr. Jasper.
Hey, Ate Afo.
Hi, Dr. Talarba.
How are you?
I'm good. I'm so happy to have you as our speaker, and thank you for doing this for us. And a few things really struck me with some of the things that you have mentioned. The first one is that kind of really make me think why they make us, when you have a contract for an EIN, at least 3 years, because I've heard from NPR, which I Googled it, wherein studies done, that is way back in 2014, and then it's still done also recently, wherein new graduates leave the profession. These are RNs, leave the profession 1 out of 5 during their first year. And then 33% leave the profession within 2 years. And so that is really like why there is such a big push of getting foreign educated nurses, because they are really supplying and taking care. You know, they are the one involved in taking care of the world, basically.
Yeah, absolutely.
Yeah, and I know that when I was working in the hospital, like it felt like we like to eat our youngs. And even when you are really cracking up, because it really like that sounds really familiar, right?
Very much so.
That is very much. And even now that I'm teaching full time at Yale, and even with mentoring students, one of their main concerns really is being mentored clinical preceptors. It's like it is such hard for that to just precept. And I like what it's. I know this is much bigger problem than what we can really think of. And with your position, having been on the CGFNS and making it much more equitable, what does the CGFNS have done in order to make it much more equitable for us to have more nurses, and even for foreign educated nurses to become like preceptors and even learn to mentor other nurses so that they will stay a little bit longer in the profession?
Yeah. That's a very good question, Ate Rafael. So let me just caveat by saying that I don't represent at this point CGFNS because I don't, this is a personal time. I cannot speak for the company, but I can tell you based on my experience with CGFNS is that it is actually creating an alumni organization where I know that Dr. Ray Rivera is part of that committee. So CGFNS has created an alumni organization where different countries have different representation. So even MJ Dia, Dr. Ray is part of that committee, and from different countries, China, South Korea. So those are foreign educated nurses who really, succeeded in their careers in the United States by going through CGFNS and now are, deans and professors and successful, career nurses in the United States. Because what they're trying to do is, again, from what you were saying, is to think about ways where we could mentor new nurses who are coming in. Okay, so perhaps that is something that we could probably invite MJ or Dr. Ray Rivera to talk about. What are the measures that we are implementing to mentor our youngs who are, because I wish when I first started here 16 years ago, I wish I had, a mentor for myself, right? To, kind of help me out. But I ended up, because I was kind of cruising on my own, I ended up being bullied at work during my first year, which ended up me being in HR and then the other person being, in EEOE. Because, I Googled at the time. I said, well, I'm getting harassed here. So then I went to HR. I complained about, the other nurse tried to bully me. So I said, I'm here 6 months new, and then this person is already harassing me. So I said something has to be done. And if you don't, I'm going to have to go through EEOC. And before I knew it, the other nurse gets suspended. But that's just me. What about those nurses who can't speak for themselves? Because it's a personality thing. Most of us don't have that sense of advocacy even for ourselves.
Mm-hmm.
And it's only through other people like us who are more experienced that can tell them, hey, it's okay to speak up. So, and we, us here in this chat room, have the responsibility, because we all are seasoned nurses. We are all have responsibilities to mentor other people, not just IENs, but everyone basically, especially those new nurses coming on in the profession. Because like what Ate Ophelia said, 1 out of 5 quit in the first year. That is not good. In the long run, it's not just them, it's all of us affected in the nursing workforce.
Thank you for that. It looks like most of us had really tried to find our way and navigate this really hard work. And even here in the Northeast, especially in the New England area, it's a totally different environment compared to the West, the West Coast. Yeah,
absolutely.
Yeah,
absolutely. Speak up. Stand up for yourself.
Yes.
As I always say.
Try to find the language.
Yeah, exactly.
Can I make a comment?
Oh, sure, Elisa.
Hi, my name is Elisa, and I'm a retired nurse. I'm a retired nurse from San Francisco, and I was called to work for my previous work because of the need to fill up positions because some people get sick, and so they.
Wow.
So
kudos to you.
Well,
What a brave soul.
basically, in addition to what I do, I belong to a group of nurses to do mentorship for new grads. And I have had the privilege to also percept and mentor master's students when I was in my position as a director of staff development with one of the city and county long-term care hospital in San Francisco. So to date, I'm still mentoring one new grad nurse, and there's a process to get in touch with them. And I have had met also nurses from the Philippines who came here as working visa, and then moved to San Francisco, and then I was able to talk to them, and part mentorship and preceptor also. And in the past, we also work with one of the school in San Francisco. We created this foreign students, like they go to a program provided by the city and county to acclimate the environment they're going to be in. And so that's how they're gonna be rehired, because some of them kind of like moved from the East Coast to the West Coast. And so I had the privilege to mentor and precept students, and I was really glad that they chose one. I'm one of them who did precept and mentor foreign students. So
yeah, that's a very good, kind-hearted, action on your part for doing that, because it's an extra work. Let's admit that,
exactly.
it's extra time. But if you come to think of it, it's also giving some of your self and your expertise to others, and that's admirable. So thank you for that.
And I just wanted to also add that in addition, when I joined the education department where I used to work, they required us to go back to school. And that was one of the hardest things that I've ever done, going back to school here, because it's so different. So, but I've learned a lot. I got to my master's, and I'm a clinical nurse specialist. Perfect. And I worked for the city for like 4 years, and then went and get to another position. So, I mean, it was actually challenging, and I do have encouraged nurses, Filipino nurses, to go back to school. Some of them also followed my lead, because when we started the cohort for foreign graduate students to go back to masters, and another group of students also came after us, which is a very good time at that time, because there are a lot of Filipino nurses that were interested in the master's program. Some of them already went to DNP and also PhD, which is also admirable for Filipino nurses. So
let me tell you this, Filipino nurses, I've never seen one nurse from the Philippines who's not bright. Let me just tell you that. They are all smart. They are hardworking, right? And whenever they go to graduate school, they do well. I'm not being biased. I'm just stating a fact that Filipino nurses are really smart. And whenever somebody asks me, like an American asks me, like, why is it that you Filipinos, like when you present like your PowerPoint is like so up, hyped? But I tell them, because that's how we get trained in the Philippines, right? It's not about just a simple text in a white thing, and we can articulate our thoughts, and we get creative and resourceful. Unlike here, I think they were used to getting spoon-fed, and no offense to them, but they expect their professors to give them the page number, the syllabus, even the PowerPoint presentation, like a week before they discuss. They want it like right there. But for us, I think, I don't know about you, but in my school, we are left to research on our own, right? We do a lot of self-learning, and that kind of developed our own initiative and resourcefulness and creativeness. And so that's why when we go for graduate school in the United States, we just shine, you know. So
Yeah, I totally agree with you, Jasper, with that, because I'm on the admissions committee with the master's and GAPN program. And then, of course, now that we remove the GRE, so we have really a slew of applicants at Yale.
yeah,
And I said, oh, that came from a good school. Philippines, they came from a good
Yeah.
school, and then, of course, I'm finding out the other programs from other countries. They said, oh, they don't have a good nursing program in that country. I said, oops, I didn't know that.
yeah,
So it's just, I am really pleased of our education back in the Philippines.
let me actually put a plug for the Yale. So let me tell you, I am not the top student in my bachelor's degree in the Philippines at all costs, right? But I'm just have a lot of grit. So when I applied to Yale, right, I was like that it's the first cohort of the DNP program, so there's no way I'm gonna get in. But then I was like, well, you know what? They just said, put yourself, whatever, sure, best foot forward. So I knew that I love to write. So when since high school up to college, I'm involved with publication, right, left and right. And I put, every time I publish something in the newspaper, I put a clip, and in fact, it's in my folder like that. So during my panel interview, they said, oh, my grade was like so-so. But then when they asked the question, what makes you stand out as a student for the first cohort of DNP at Yale? And I said, I'm not just a nurse, I'm also a writer. And in fact, I brought my whole portfolio of writing in the room. So they said, oh, let us see that, because there's like 3 people there. So they circulated, and then they opened. So they were impressed that here I am, I'm a nurse, but also I write a lot. So I was lucky enough to be one of the 12, cohort of DNP program. So the moral of that story is that if you have a master's now, please don't get yourself too intimidated by the name. There's no magic formula there. Please apply. I was like doing that, but I'm telling you, please apply to schools. These top schools, just highlight what you have done, what separates you from the rest. If you have a bachelor's now, apply to the top school with a master's program. Just highlight what makes you unique for the program, because most of these schools, they're not looking for the grades. They are looking at what can you do to make the university proud when you graduate later on. So that's my personal experience. I'm not bragging. I'm just sharing as a kind of like a snippet for your own purposes that I'm encouraging you to apply for further studies.
Can I
Yeah, Jasper, if it's a fact, it's not bragging.
Yeah, but being in the admissions committee, you are absolutely correct, Jasper, because there are things that we are looking why you want to become a nurse practitioner. What makes you really different?
Yep.
Because we have some applicants from amazing school here in the US, top school, high grades, but then their essay didn't really make it.
Yeah.
Yes.
Yeah.
Yes. So,
It's what makes you unique. What
yeah.
will the college make them proud that you are an alumnus of that? And please, feel free to apply to these schools.
I know that Ate Paz have had her hand raised, but I also just wanted to have a comment. I also have this people in our participants today who are attendees. There are also in leadership positions. So me as being in academia also, I really hope that we're not just looking at grades, but we really wanted to diversify the population of our students, because that's the type of patients that they will be dealing with. So I usually advocate a B student may not have that big GPA, but all the adversity that they have to go through. They're a single mom. They're from, like a low income family, but was still. So I think we need to diversify the type of students that we are taking in, or employees that we are taking in. So there'll be more empathy. But
couldn't agree more.
Rather than so Ate Paz, please unmute yourself. Thank you for waiting.
Yeah, that's fine. It's such an interesting topic about admissions and all that stuff. I don't have a question but a comment, and thank you, Dr. Jasper, for such a thought-provoking topic. My comment is just that it has, I sat down and thought about this global pandemic, and I think we should be afraid, personally, as a nurse, just because we know that if you're taken care of by a wonderful, great nurse, you'll have a great experience as a patient. Now, I don't know about you guys, but we're getting into that age where we're getting to that point where one day we'll be patients.
Yeah.
And with the thought of global pandemic, it doesn't matter where you are. You might be in the US, you might be in the UK, you might be in Germany, but you or us or we will experience that point where nobody will take care of us.
Yeah.
So I think we all have a responsibility to delve more into what we can do as a group or as a person into preventing this global pandemic.
Absolutely, 100%.
Thank you,
I totally
Pastor.
agree,
You are correct.
I totally agree. Yeah.
Yep.
But I would like also to add to that, that I hope we are also motivating future nurses that the motivation is not about the money, but it's actually the true self, essence of caring, not because they're getting into nursing because they see the security of job or monetary.
That is correct.
I know, Dr. Jasper, that's true. But at the same time, we really need to advocate that. And yung mga hospitals, they need to compensate us too. I know, we care, pero sometimes hospitals, they really lowball yung mga nurses despite the pandemic. We even went to comedy shows, Nurse Blake last week, and he said he was expecting that the Nurses Week this year would be really awesome, pero hindi pa rin.
Still a cup and then a pen.
Actually, he said it's a rock because nurses rock. A lot of hospitals gave their nurses an actual rock with a motivation. Oh my.
I actually mentioned that in one of our meetings that, it's not right that that we are giving cups or, like you said, pens for this Nurses Week. We got to do more to show our appreciation for everyone's hard work. And I think a cup just doesn't do it. A coffee cup doesn't do it.
No. And that is why they are resigning. I'm telling you, travel nurses, at the start of the pandemic, prior to pandemic rather, one agency that I know of, there are only about roughly 7,000 travelers. Right now, they are about 50,000 jobs for travel nursing. And they can only fill 30,000 of those 50,000 jobs. Imagine that. So from 7,000 before pandemic, the volume of those vacant nursing positions nationwide in the US is now 50,000. And we can only fill 30,000 of those 50,000. So 20,000 is still empty. So going back to what we were saying, those nurses that are not satisfied with their hospitals because they're just receiving cups, they are going to resign and join travel nursing sooner or later.
We really need to, think of ways. Let's be part of the solution instead of the problem.
Yeah.
Right.
And it's on the initiative of hospital leaders, really.
Lots
they
of
put
discussion.
out this multi-million, a hospital, like Penn just opened like a multi-billion, hospital there that's like too shiny, like a gold. But then what are they doing for the nurses?
Yeah.
What's interesting too is if they pay their nurses the rate that they're paying their travelers, then guess what? Nobody's going to leave.
Absolutely. And that's absolutely right.
And the excuse that I heard hospitals say, they're only temporary. With you guys, it'll be a permanent thing. But that's no excuse. No. There needs to be, meeting halfway where it's win-win for both.
Yeah,
absolutely.
And definitely more nurses that's representing us, like the foreign graduate nurses. be part of the leadership or the management positions as well.
I know, pero sometimes it's so difficult, especially for us nga. Like, how do we push them to pursue leadership roles? Minsan like, oh, ayoko ng stress. I just want simple, like, all that stuff. Pero like, we really need to rise.
Yeah.
Okay.
Anyways.
Well, in respect of all your time, we'd really like to share the book that Dr. Jasper has co-written. I think we had the question. Did anybody come up with an answer on that question?
We're like carried away with a side conversation.
Let's get to the second question. I think the second question was much easier. Okay, there's the second question. Using your best guess, how far did our global nurse shortage jump from pre-COVID to post-COVID? Did anybody get that?
I think that was 17 million. Right? That was 17 million. It's your turn.
From pre-COVID to post-COVID, how far do you think the global nursing shortage jumped up from?
17 million. I don't know how many percentage is that. Because I was just remembering doing the addition.
I think
the difference before and after COVID.
Yeah, the difference.
Okay.
Do you have an answer slide to that? Do you have an answer slide to that, Minette?
How far did our global?
I'm not sure if I was looking at the right numbers, but I think this is the value. It was.
Is that right, Dr. Jasper?
It was 11.9 or 10.9 before. Now we are 14 million after COVID.
Oh, okay. I was looking at 5.1 and then 14 million. So,
I was over 3 million.
You're over 3 million, but it's close.
You're still close. So we can send at the office the book.
Right.
Yeah, I'd be honored to get your book, Dr. Talarba. Please sign it for me.
Yeah, and then you can share it with a lot of, because you're in the academe, so you can share with a lot of foreign educated students.
Yay.
Thank you.
Ate Aida also posted her answer on the chat.
Oh,
13 million?
Yeah, 13.
Close. Yes.
Well, we have 2 to give away, right, Kate?
So,
yes, we do. Yep.
So at the Afi and at the Ida will get the books.
Yes.
And then, again, in respect of your time, we're just going to proceed with the rest of the program here, the presentation. We're just going to mention some of our SLUNAAI updates. We have a slide. So we just want to inform everyone that SLUNAAI has been approved for the U.S. Internal Revenue Service as a tax-exempt charitable organization. Thank you to Ati Alfie and Ati Maricon.
And Minette.
And Minette. That's right, Minette. So charitable is broadly defined as being established for purposes that are religious, educational, charitable, scientific, literary, testing for public safety, fostering of national or international amateur sports, or prevention of cruelty to animals and children. What this means is it is approved by the U.S. IRS as a tax-exempt charitable organization. Any donation, personal and corporate, can now be tax deductible in the United States. So I guess my question then is, our conference in Vancouver, is that then tax deductible since we're going to Vancouver?
Kuya Dino, will you be able to answer?
I know about the donations, for corporate donations probably, but I don't know about personal.
Conferences. Maybe not then.
Oh,
so it's just donations.
Not yet. Probably not yet because we moved away from that for a while. Yeah.
Okay.
Yeah.
Then I'm sorry, Minette, I cannot see my slides. Sorry, would you mind reading that for me?
Oh, sorry. This is about our save the date for our grand alumni homecoming in 2022, July, in Vancouver. You all are invited.
And then our next slide.
Oh, by the way, it's probably the most beautiful city I've had to fly into. Nasa
Okay.
air ka pa lang, you're falling in love na.
Wow. And we have our SLUNAAI initiatives. Sorry, my slides are not opening up well here. Really hard. Go ahead.
So we have a scholar, and we do community outreach, and we do education and research, and we will unpack that in the next few slides. For community projects, at the Annie, did you want to cover that?
Sure. So for the community outreach, we had some donation of 5 portable hand wash stations. So it was a project spearheaded by the Benguet Society of British Columbia, care of Kuya Cliff, partly in collaboration with the Red Cross and Benguet chapter. Also, the provision of KN95 masks for 85 SLU School of Nursing faculty members. And for partnerships, for Grand Canyon University, if you go back to school with GCU, through the SLUNAAI, if you are a member, you get 15% discount on all MSN program and 15% discount on the DNP program. So if you have your BSN, take your MSN, just like Dr. Jasper said. And if you have your MSN, move on and apply for your DNP program. For the Walden University, graduate school tuition discounts, free webinars with CEs, and more details to follow on that.
All right. And members.
And if you already an SLUNAAI member, these are the initiatives that we have that you can get, have the ability to get. You get be able to attend presentations, networking, continuing educations, career advancement, service to colleagues, such as the service outreaches, and giving back to SLU College of Nursing and the communities, and staying in touch with the alumni all over the world. And again, our face mask for cost, they are all available in our website. Just make sure you size up. When you purchase, size up. And again, the save the date. Another save the date. This is for our Christmas special for next Zoomustahan. That would be care of Anne. She had to leave. Her phone was dying. This is for December 17, 5 p.m. California time, 8 p.m. Eastern Standard Time, and 9 a.m. in Manila. And again, we are very grateful for you all to be, Ate Ida.
Okay. I just have a question for your event next year.
Yeah.
Do you provide CE hours?
I'll answer that. This is Kay. We're in the process of getting all of those sorted out. So by January, when we open it up for registration, we'll give you more information. But that is the goal, to give all the attendees for the Grand Reunion CEUs as well.
Yeah,
Great.
because the other thing too, if you are 501c3 already, and you will be providing CE hours, some portion of the expenses of the attendees, they might be able to use it for tax deduction, but sometimes it's not. Especially if you are a 501c3 here in the U.S. and you're the one who is hosting or sponsoring the event, you might be able to do that one, because that's what most of the 501c3 requirements.
So that kind of answered the question earlier then.
Education.
Oh, that would be great. That's great, Karen. Thanks for bringing that up.
Thank you so
Any
much.
other comments, any other questions before we close this? Well, thank you all again. Thank you so much to all. Thank you so much, Dr. Jasper, to all alumni, family, and friends.
You guys.
Thank you for inviting me.
Thank you for.
Dr. Talarba, you make us proud.
We hope to have you next year for the next
I'll see you.
discussion.
Hopefully, I can visit you there in New Haven.
Yes. Dr. Talarba, next year we're booking you another topic.
Absolutely. Anytime. It's been a
Thank
pleasure.
you.
I actually really enjoyed this conversation. It's more like an informal conversation. I had a lot of fun. So
Thanksgiving.
Bye-bye.
Ingat. Bye.
Bye-bye.
Bye.
Bye.
Stay safe. Bye.